All right, welcome back to the Pure Playbook. I'm Dr. Dustin Bosson with Dr. Nate Merhaut. And this episode, we are going to be going through the twisted truth of ankle injuries and what student athletes and their parents should know. So that's, again, what this is all about. Pure Playbook is all about bringing relevant information to student athletes and their parents trying to keep up. Our job here, because of what we do at the Pure Athlete, our healthcare facility, is to provide elite level healthcare for these student athletes and their parents trying to keep up. So when it comes to injury prevention and taking care of injuries from an acute standpoint or even a chronic standpoint, we just like to jump on here, banter a little bit, and go through and give you guys insight into this ever-changing world of information and in healthcare and in research. And we combine all of those together to not be reactive about these scenarios, but in this one, literally the twisted truth, the twisting of the ankles, the mechanism of these injuries look a lot like that no matter what you injure in these ankles. But the reason we want to go over this is because it's one of the top injuries that student athletes see. We've talked about this before. We've gone through kind of the top five, kind of alluded to almost 10 of them, but in the top five, ankles and knees are way up there. And then you have head and face injuries. And so let's just kind of go through and banter around here a little bit, give some great information, and we're going to tie some research into this as well. But why I kind of went out this and when everybody looked at me like, oh, what are we talking about next week? And I was thinking about this over the Memorial Day weekend, and I'm like, man, let's really start to make the loop. And we've talked a lot about what we do. We've been very I don't know if inspiring is the word, but we've talked a lot about our mission and our purpose of what we're doing here, not only on these episodes, but in the healthcare facility. And so it's for 40% of these athletes, or 40% of these injuries are what make up athletic injuries for student athletes. So ankles are a huge deal, but they could be one of the longest times spent out. That's non-surgical. You have a high ankle sprain, and it can be very nagging too. Right. So I wanted to make the whole loop of how's it happen? What are they? What do they grade? But more importantly, what could this cost down the road? Like what else now is going to be more susceptible if not brought back correctly? Right. And also why you want to go the injury prevention route with the bulletproofing protocols that we're doing here in office. Right. In the summer is the best time to do it. I mean, talk about, yes, there's club sports, but it's like, this is the time to be doing that. So kind of go through and touch on that. I've talked a little bit so far, but that's where we're going if you didn't know.
Yeah, I think like you said, 40% of all sports injuries in student athletes are ankle sprains. Mm-hmm. And I knew you were trying to word it that way. So there you go. You're welcome. I worded it a little bit better for you to understand, but 40% is what he was trying to say of all student athlete injuries are ankle sprains. So that's a very high number. And it's almost, to where it's half of injuries in student athletes are ankle sprains. So why not focus on that from a preventative standpoint? Because we see it all the time. And anything from a grade 1 to a grade 3, which we can get into on what that means, and we will in a second, on what the grading is, what it means, and what the time frames look like on average to be sitting out with some of those injuries and the severity of them. But on another note, 70% of athletes will experience an ankle sprain at some point in their career. So that also, the majority of athletes are going to have that type of an injury at some point in their career. So again, can we be preventative and bring that number down? And that's the goal of what we're trying to do here. Mm-hmm. So to get a little bit, I'll probably be more on the technical side, and you'll rein me in and be more on the story side probably, but I'll get into the grades just since we'll set the tone on that so you can understand what they are. And it's anything from a grade 1, 2, or 3. And that's going to be, most soft tissue injuries are going to be graded that way as well. So grade 1, meaning that there's slightly overstretching of the tissue. Now, when we're talking about an ankle sprain, it's going to be the ligaments that are holding the bones and joints together at the foot and ankle. A grade 2 is going to be a partial tear. So you're going to have grade 2 on any injury is a very large category from where you can sit. So as soon as there's partial tearing, it's considered a grade 2, all the way up to right before it's a complete tear. Yep. So it's a very broad range of an injury in a grade 2. So if you have a grade 2, know that it's it could be a good grade 2, it could be a bad grade 2. I almost would want it to be broken up even more than that, because even the rehab and the timeout is different based on where you are in that grade 2. And that's where imaging comes into play, is when we would want to see how severe it is. And we just had this scenario last week. We had to know what grade it was and how severe it was.
Right.
Grade 3 is going to be a complete tear, rupture of those ligaments. And that's usually when there's a little bit more less conservative treatments that are being done. So oftentimes surgery is an option at that point on a grade 3. It doesn't have to be, but oftentimes a surgical intervention is recommended depending on the athlete, the sport, where they are in their life and what's going on. Sometimes we also see with these ankle sprains a combination of a sprain, strain. So there's a muscle involvement or a tendon involvement. And then on top of that, we sometimes and commonly will see a fracture.
Yeah.
And that could be, a lot of people hear a high ankle sprain, and we can even get into what that means, whether a high ankle sprain is involved with a fracture. Is it involved also with the tissue that connects the two bones in the lower leg, which they're the tibia and fibula? So that's kind of a large, for lack of a better term, ligament in that area that can be slightly torn or overstretched. Or
the syndesmosis.
Exactly.
As we call it in the business.
Yeah. So there are lots of different, I guess, categories or types of ankle sprains. Most people, when they think about an ankle sprain, they think about rolling that ankle outwards. And that, I don't think we have that number, but that is the most common way to sprain your ankle. You can do an inversion sprain or an eversion sprain. The eversion sprains are more of the high ankle sprains that often we see. But I'll stop being technical on you, and you can maybe talk about some of the cases that we've had recently.
Yeah, and so what we might do, if we can get techie enough, if we have the time and capacity, what we'll try to do is, and I can't promise you on this one, maybe I'll try to figure it out, see if Erica on the back end of this can kind of throw up some anatomy as far as what we're looking at, because we talk inversion and eversion sprains, and yes, they're different, but the most common that you will see is you will see the bottom. If this is my foot, you see the bottom of the foot turn in and the legs stay upright. You'll turn that foot in and literally roll the ankle, which, yes, high ankle sprains are one of the leading injuries, like you had said. Now, this is something we do see a lot. Okay. Now, for you guys out there, it's one of the most frustrating things, and I was that person growing up, where it's just like, okay, right ankle, left ankle, done them both more than 10 times. Thank God didn't break anything, but we didn't know, small town, didn't have a whole lot of resources or a whole lot of knowledge in that. We were just grit and get out there, play, wrap it, ice it, do all those things. And we'll get into that. But here, it was even a couple years ago when the Pure Athlete started to really take some traction, and we found that road we wanted to go down to serve them better. Is we had a local D1 athlete who senior year, his 5th year, senior year, they had probably 6 weeks left in the season. And one of the captains on the team was looking at an opportunity afterwards, and 6 weeks left in the season, has this high ankle sprain injury. Boom, folds that sucker over, and that looks like an orange, like hanging off the side of the lateral side of his foot and ankle. And so with imaging, take digital x-rays first. Is anything broken? Nothing was broken. They did MRI and they said, oh, there's laxity in the ligaments. They called it a grade 2. And it's like, okay, so was there tearing? Was there not tearing? So there was partial tearing and even fraying at that. So there wasn't a full thickness tear, but he's, one of the guys on this defense. And it's like, well, what are we going to do? And they said, you're done. Senior year, D1, opportunity afterwards, and done. And it's like, I don't care if you're 12 or 22 staring down the end of the career, it sucks. And so it's like, okay, immediately in that scenario, it's like, what do we do now to get this guy back on the field morally, ethically, clinically, as quickly as possible? Can we do it? And I had to be honest with him. It's like, we're going to try. We're going to whole ass get after it, and we're going to try and get you back on the field. And we're going, and he's getting discouraged, and we're doing everything right here. And this was before you were here. Otherwise, he'd probably been back faster. But he starts getting discouraged, and then all of a sudden we're doing soft wave, he's getting adjusted, we're doing recovery techniques, and there's so much that goes on with this where all of a sudden he woke up and he's like, this is the first time I've had zero pain. And we're 2.5 weeks into this. So he's already missed 2 games. Actually, I think they had a bye week. So that was kind of a blessing. It's like, okay. Long story short, he gets to play the last two games of his senior season. Huge deal.
Right.
Like, holy cow. Didn't end up going on and playing anywhere else, but that alone was closure of that chapter. And if we can bring that, because these injuries are going to happen. I had that conversation this morning.
Right.
Like, injuries are going to happen, but to have one of these injuries that oftentimes can be prevented, and we can get down to the prevention of this, and these, prevention programs can reduce sprain risk by up to 50%.
Right.
And, that's from an orthopedic journal. And so this is why it's like, on the acute side, we can be very good. And that's where a lot of people enter this story, is like, oh man, he's hurt. I hate that as a parent. I hate it. I hate seeing my kids hurt or sick. But now how do we get them back? How do we get them back on the field? We got, and you got all of these things going through your head, that it's like, okay, once we get past that, if we could talk on anything, and we cut this up last week on one of the reels that we're going to put out, and it's you talking about, if we can see you guys on the preventative side because of the anatomy, like, you think about these ankle sprains, and I'm gonna have you talk about this. We talk about these ankle sprains and what's involved from an anatomy standpoint, and everybody thinks of, oh, there's all these ligaments around the ankle, and it's like, okay, but where do those come from? And what about the tendinous junctions? Where do the muscles start that wrap around underneath the foot? And so you think about, if you learn more about it and you start to think logically about, again, what if the ankle's not the problem? So now not only are we talking recovery, we're talking prevention, we're talking acute care. Like, there's so much wrapped up in this, but that's how you can be even more preventative, is understanding the anatomy and what's actually involved, and how the preventative mechanisms work. So as we kind of cruise down through this over the next, 20 minutes or so, let's just kind of take them through a little bit of that, because this is a lot of people's story. That story of that athlete, that D1 athlete, is the same story that we've had in here with, we've talked about Bailey quite a bit, but with her scenario, where not a high ankle sprain, definitely foot and ankle issue, broke the 5th metatarsal. And so now we're looking at something that is 8, 10, 12 weeks worth of rehab,
right,
that we're cutting down at this point as quickly as possible. So there'll be more coming out on that. But there's so many of these athletes that, just done, watch and wait, 4 to 6. That's it.
Yeah.
And there's more that can be done and should be done.
Yeah. Even with Bailey's, we didn't get a very clear cut answer on the actual ankle sprain itself, the soft tissue damage that was in there. And we knew it was at least a grade 2, just by how it looked. When there's a bruising pattern and the way that it looked, the swelling, and when we're feeling around in the laxity, we know it's at least a grade 2 in that scenario. But for her, the immediate concern was the spiral fracture in her base of the 5th metatarsal, and getting that stabilized so that we could start with some of the other stuff. And by the time we got to, or we're starting to get to some of the other stuff, whether it was a grade 2 or grade 3, some of those things are already starting to heal, because she was in a hard cast for a period of time. Yeah. And so even just knowing the process of what happens when there is an ankle sprain, because some people, it is to watch and wait. Like, I would say the majority of ankle sprains are very well underserved when it comes to what you should be doing. And a lot of times it's, you sit out for a game or two and you don't really do a whole lot. And with going back to the grades, grade 1, you're going to be anywhere between 1 to 3 weeks out typically. Grade 2, it's going to be 3 to 6 weeks, similar to your scenario in the story you just told, where it was like 6 weeks you're out, but he got back probably within a 2 to 3 week time period to get back and be able to play the last 2 games. And then the grade 3, it can be a couple months to even longer, depending on the complexity of what's actually torn. Is there ligament damage? Is there a spiral fracture? Are there other things that are damaged? Is there muscle tendinous junction things that are also damaged, which commonly go undiagnosed because there's not always imaging that's done when there's these soft tissue injuries, because it's such a common thing. It's like, oh yeah, we basically think it's a 2. If it was a 3, it'd be a lot more lax, and it would be a different story, whether it's surgical intervention or something else.
And before you continue down that route, I'm going to go over kind of the worst case scenarios. That way you can talk about all of it in sequence here. is the worst case scenarios, okay, that everybody needs to know about is like down the road, either immediately or chronically, you could end up, if not treated correctly, diagnosed correctly, and worked through beyond the typical PT pattern for rehabilitation. For athlete rehabilitation, it looks different. But the worst case scenarios right off the bat, we're talking chronic ankle instability. So that just redoing it, one side, both sides, doesn't matter, just always spraining the ankles. Now you're the person with the lace up splints and braces and things, which that's a whole nother opportunity to talk about as far as education on why that's not the greatest time and place. Development of osteochondral lesions, so cyst formations in the bone, which then advance arthritis faster in between the joints. So now, you're invincible when you're 12 to 22 to 24 to 25, and then they say 30, be careful, and after 40 it's all downhill. And I hate to subscribe to that. And the reason people subscribe to that is because the mode of diagnosis and the care given has not changed enough to combat the fact that this happened when you're 16. Now you get to look forward when you're 40 going downhill. That's not true, and this is what needs to change. And also, but there are times, or if not diagnosed correctly and taken care of correctly, either from a traumatic standpoint during a game or not being taken care of correctly, now you're risking things like surgical intervention or tearing apart multiple ligaments in a complex of an ankle, or we're talking about ankles for right now, but then also to what is that becoming more, what's that creating more susceptibility to another injury. So but when you talk about these grade 1, 2s, and 3s, and you mentioned some of the imaging, it's like, okay, just kind of take them through. If somebody were to call today and be like, yep, my kid's got an ankle injury, happened this weekend, soccer game, baseball game, whatever it is, what are you guys going to do? What's your thoughts as far as?
So first and foremost, it's usually questions and a physical exam on, do we need to take imaging? And most of the times we are going to take imaging, but there are guidelines out there that specifically, it's called the Ottawa ankle rules that I can briefly go through. But one of the big things that I always ask was, were you able to walk on it immediately after? Were you able to get up off the court? Were you able to walk off the field under your own weight? If you were not, then automatically it's an x-ray. Because if you can't bear your own weight, then we need to know if there's a fracture. Most likely there's soft tissue damage, but we definitely need to know if there's a fracture if you can't bear your own weight. Although also know that if you can bear your own weight, there can still be a fracture in the fibula, because the fibula does not bear, some people argue, it doesn't bear enough weight to where if it was fractured, it would hurt to walk on it. So that is a common misnomer, that even if you were able to walk off the field, that there is no fracture. And that's where the other components of the Ottawa ankle rules are, where you actually have to palpate and push into certain areas. So we push into the lateral malleolus and the medial malleolus, which are those bony, kind of prominent, sticky out things. If there's a better
the
term
little
for
knots
that.
on the
Those
inside.
little balls on, so if you're pressing on the back portion of that and there's tenderness there, that's going to indicate that we need to get
immediately you come in here with an injury like that, you're getting an x-ray.
So we're going to roll that out right away to make sure that there isn't a fracture, and if there isn't, then we can be a lot more aggressive with our treatments to get you back faster. If there is a fracture, that's a different story. Does it need to be immobilized? Does it need to be a hard cast, a walking boot? Sometimes there's consultations that we'll have with orthos to determine if that's necessary. Does there need to be pins, screws, those kind of things? So to answer your question, the consultation and exam happens first to basically tell us what next steps are. Is there an x-ray? Is there soft tissue damage? Do we need further imaging, whether it's a diagnostic ultrasound or an MRI, to determine the severity, the grade 1, 2, 3 that we were talking about earlier with the soft tissue, ligaments, tendons? Is there muscle involved in all of that?
What's the ultrasound going to show? I mean, we talked about x-ray. X-ray is very good for the bony structure. There's nothing better for bony detail than digital x-ray when done right. When collimated in diagnostic. So I'll spare that conversation. But for the most part, don't hear what I'm not saying, but there's nothing more sensitive than a digital x-ray to be able to see fractures from certain angles. That one's very good. But why move into ultrasound? Why is ultrasound important in these injuries?
Well, the ultrasound can detect certain hairline fractures that an X-ray will not. So
and let me clear this up.
Thing.
There's therapeutic ultrasound that is a treatment for symptomatology, and again, I'll spare you, but it's not the little thing that they rub and for therapeutic, for like, oh, I got stinging in my elbow. Some people would use that, or looking at babies. That's a little bit more about what we're talking about. We're not talking about symptom relief. We're talking about imaging.
It's the same mechanism to get, but this mechanism uses the sound waves to get an image. So they bounce off and they create an image through the computer. So we're looking at, it could be a hairline fracture, which is going to be, if an X-ray doesn't pick it up, the ultrasound can pick it up in those scenarios. It can, but it can't go down deep into bone. So that's where X-ray is going to be better to determine spiral fractures and other things like that. It's really going to be good at looking at the ligament damage. It's going to be able to look at if there is soft tissue swelling within the tendons. It's going to be able to look at, is there vascularity to certain areas? Is this something that just happened, or is this something that's chronic? And there's areas of
active blood flow
that you can look at on a Doppler ultrasound, which you'll see the little red or blue dots of blood flow going towards or away from the heart. So you can grade it. Sometimes there is too much soft tissue swelling to grade it. That's where the MRI comes into play, to where it's like, okay, yeah, we'll start with this. We'll see what we can see. If we can't see anything, then let's go MRI route. And you had a perfect example of that when we had a real bad ankle sprain here about 2-3 months ago. And you literally said it because you were managing the case, where we could get the diagnostic ultrasound. It's probably not going to show enough because there's too much soft tissue swelling. And that was the case. And they had to end up going and do the MRI instead and get a little bit more detail, because the MRIs can be the most detailed for the soft tissue and tell you what's damaged in that area. So that's pretty much what we would use ultrasound for from a diagnostic standpoint, to grade it, as well as look at what structures are affected in those areas.
I would say for a lot of you out there that are listening to this, like, especially if you're in our area, or like I say all the time, if you're not, we'll find you somebody. But honestly, this is why we're considering adding it to our practice, and also positioning with people who do it every day, is that we can get diagnostic ultrasound on site, or very, very quickly within 24 hours to make sure we know exactly what it is. It's one thing if general civilian has one of these injuries, you step off a curb on vacation, you roll your ankle, it's like, oh man, watch, wait, give it time, rest, hopefully still rehab it properly. But with these athletes, it's very important to know, okay, rule everything out. We know what it is. It's a high ankle sprain, but what all is involved, what all is not, gives you a lot of information on how to treat it very quickly and get these athletes back faster.
Right. And knowing what it is and the grade it is very important, because that's going to, one, tell us how we can give them recommendations. Can they play at the end of the week? Is it going to take 2 weeks? And give them those expectations, because if they're not going to do anything from a rehab standpoint, then that's where the chronic ankle instability comes into play, where it's going to be a recurrent injury. When I was looking up some numbers on what is the recurrence rate, it's close to 50%, which I thought it was going to be a lot higher. And I think that's just, most of the time, the ones that reoccur just aren't reported.
I was going to say the reporting.
So it's probably closer to 70 or 80% is my guess on, if you ask anybody that's sprained their ankle, ask them if they did it again, the answer is probably going to be yes. So and the other question to ask them is, did they do anything about it the first time around? The answer is probably going to be no, that they didn't. So from a preventative standpoint, as well as a decreasing the risk of re-injury, that's where we come into play on, do you even want to deal with an ankle sprain? Do you want to be in the majority of the 70% of athletes that have it within their career? If you want to be in that 30%, then do some preventative stuff. And I'd be curious to know that 30%, are they doing preventative stuff?
And here's what here's what we're kind of running into right now, which is exactly what we want to change, right? It's where do we go? Who do we trust? How do we prevent? Top 3 questions. However, when it comes to answering those, or we're in the moment, and sometimes I'll be the first one to admit this, I am not perfect, and I need to keep this in mind myself, is, toughen up, get up, we'll just wait, just give it time, stick it in the boot, don't move it for a while. And we just kind of like, we got it, like taken care of, like, and we're trying to actively change that because there's a lot at risk here. And it's okay not to know. And it's, but sometimes as parents, we get a little too overzealous when it comes to, oh, I'll be fine. It's like, no, you're walking on it. It ain't broke. We're not trying to find that it's broken.
Right.
We are trying to figure out how to get them back as quickly and as safely as possible and prevent it. Because a lot of times it's like, then we feel terrible as parents where it's like, oh man, you mean we could have prevented this? Or it's like, man, I wish can you even prevent it? I wish we knew if you could prevent it. And it's okay not to have all the control in the world and all of the answers in the world, but it's a very dangerous line to just be like, we'll deal with it if it comes, because every time that happens, there's more time, there's more money, there's more agony, there's more mental, and there's more further injury down the line. And because of the prevention you're not doing now, you're almost guaranteeing susceptibility to a more catastrophic injury later. And that's what we're trying to provide. Honestly, I think we love being on the injury side of care, because we know chances are dollars to donuts, as my dad used to say, we're going to be able to get you back faster. And if not, we'll tell you that. But with what we do here, I would say more often than not, we're back before what most people would say. Clinically, ethically, logically, morally, we are back ready to play. So do the preventative things now. And if you have one of these injuries, take care of it better, have it reevaluated, come see us, let us get another set of eyes on it, just like we do with the orthos when we need another eyes set on it, because the other injuries that can happen after this are still just as real, just bigger capacity.
And that's the big thing, is we're uncovering so many previous ankle, like, I don't know how many times where we go through an evaluation and I say, look, during this part of this exercise, your ankle stability, your endurance through the muscles of the lateral ankle are not very good. They're not where they should be. It leads to susceptibility to ankle sprain. And usually mom or the kid's like, oh yeah, I've had 3.
Yeah.
And it's like, okay, was it this side that I'm showing you now? He's like, yeah, I think it was. Did you do anything about it? No. So from a preventative side, even after, when we're talking about ankle sprains, after the ankle sprain, the preventative stuff comes into play on being preventative for the catastrophic injuries that you're talking about, the knees, the hip labrums, even low back injuries, stress fractures, shin splints, those kind of things. Because once the ankle's unstable, because the ankle needs to be stable at certain points in performance, once there's instability in the ankle, it goes all the way up the chain. So everything else has to compensate from there if you didn't correct for the instability at the ankle from an ankle sprain, one that was recurrent over and over and over again. So the Journal of Athletic Training, you have this pulled up right here, is, the history of ankle sprains is significantly increases the risk of ACL injuries when you've had one. So if we're on the preventative side for more of the catastrophic injuries for ACLs, which is a big one that we see, then, taking the history and asking them, have you had ankle sprains? And if they say yes, then that's something that's incorporated into their program. If that's not a question that we're asking, or something that they brought up to us, we can usually uncover it, like I said, with the evaluation that we're doing here, and say, you probably had ankle sprains in the past. And they're like, yeah, I've had some. And they just kind of brush it off.
Yeah.
It's one of those injuries that's brushed off and not addressed that will impact everything else from knee, hip, low back, even all the way up into the shoulder. Because with pitching mechanisms, which you could probably talk a little bit more on this, is when you're creating force through the ground, it has to go through your ankle first. And if it's dispersing force differently through the ankle, it's going to make your arm and elbow and everything else above it work a lot harder. That's where UCL and rotator cuff injuries come into play. So from the ground up is what we're looking at.
Just because these, and you bring up a good point talking about, it's very overlooked. And I think it is because of the rate at which it happens. It happens so often. Don't confuse the amount of times or the frequency that this happens, that it is normal. It's like, oh, that happens in sport. They'll be okay. Just like I was a kid and all these other kids, they've got teammates that do it. Oh, they'll be all right. It sucks. It'll take a few weeks. And it's like, just because it happens so often doesn't make it normal.
Yeah.
It makes it
common, but not normal.
It's not normal. So keep that in mind, because what is normal is that an injury can take you out of a sport that fast.
Mm-hmm. Yeah, definitely. Jumping into a couple of the research articles, the one that I found interesting was they said ipsilateral, which means same side hip abductor, so same side butt muscle, weakness after inversion ankle sprain. I would argue that muscle is already weak and oftentimes is part of the cause of the ankle sprain, because we know that with dynamic valgus stresses and loads, oftentimes it's the hip or the ankle that's causing that. So if there's lack of control from the glute muscles on the side and your hip shifts out to the side, that's going to cause the ankle and the foot to pronate, supinate in different ways. So chicken or the egg kind of a thing. Is it ankle sprain causing weakness in the glute, or is there weakness in the glute leaving you susceptible to an ankle sprain? And I would argue that it's the weakness in the glute that's leaving you susceptible to ankle sprains. And that's something that we target when we're doing a lot of our preventative stuff.
They uncover that finding because of the injury. However, I bet, like, if you were to test it, like you said, you would have found that weakness was already there. So again, this is where the preventative, like, they're literally telling you without telling you, like, oh, we see this a lot, and that glute med muscle, or you need to work on the lateral side of the legs and those kinds of things. It's like, they'll tell you that, and it's like, oh, okay, thanks.
Right. So you can use this.
Why aren't they telling you this before?
Research to be reactive and say, oh, you've had an inversion ankle sprain, we need to strengthen your hip abductors. Or you take it from the preventative side, like we are, and say, you have an inversion ankle sprain, or we want to prevent inversion ankle sprains. Let's already get ahead of it and strengthen your hip abductors, because we don't want them to be weak.
This is more than just spelling your name with your foot as a preventative exercise.
Right.
Okay. And let me say this. I was thinking about this over the weekend too, and I'll go on a longer rant on a different podcast about this, just because this is where my heart is. And this is one of the things I want everybody to understand is stretching is not an injury prevention protocol, period.
Right.
It is not. It could be a part of an injury prevention protocol, but being in Vegas this past weekend, still getting our workouts in, and still having some kids there. There's a couple tournaments going on. You could tell, with soccer tournament and stuff going on, and you got some of these parents or these young kids or UNLVs down the street, and whatever the case might be. But they're, oh, I'm going to do some upper body today, and they're hugging themselves doing this, or they're lying down. I watched this last night at the gym, and they got their daughter doing static. I'll sit here on the squat base first, and we're static stretching. Not saying it's a bad thing to do. I'm just saying that you want to talk about injury prevention and building and protecting and building student athletes better. Just please hear that stretching is not an injury prevention protocol.
No, it's from what the research shows, it's showing that it is going to more so enhance performance. There's very little that actually shows it's going to be preventative from an injury side of a thing. If you're doing even the right kind of stretching, if you're doing dynamic stretching prior to working out or your activities of sport, it's not, most people think they're doing it because they're trying to prevent an injury, is what I'm getting at. Yeah. And that's not the case. There are so many other things that we should be doing from a preventative standpoint, and stretching is not one of them.
Well, and chances are you're doing the stretching that you're probably going to be given anyway. So you're either not stretching, or you're going to do the simple stretches that you're given anyway, the static stuff. So, I mean, I would also, if I'm going to get a little bit on a rant here, I would also say, if their first answer is you need to stretch more and be more mobile, run. Just run.
Yeah.
Just be like, very graciously, oh, okay, yeah, love it. Yeah, we'll definitely look into that. And then run. But also as a parent thing, it's like, oh yeah, we stretch her and we do all that stuff before the game, and we get the massage guns out as preventative, like, or if they have an active injury, it's even scarier, because I've heard this too. It's like, oh well, I've been through these injuries before in college, and we'll take care of it. I'll make sure she's stretched and everything, and that'll help rehab it. And it's like, oh no, like no. That's why we want to talk about this.
And I've talked about this too before, and this is a little off topic from ankles, but if something feels tight and you're stretching it over and over again and it just is not changing anything, stretching's probably not the answer.
Yeah.
So, don't just keep doing something just because it was said by a coach or an athletic trainer or another chiropractor or physical therapist, anybody that told you, you know, start asking questions on why isn't this getting better after I stretch it? Or should I be doing something different? And that's where we're giving the resources on each individual athlete, what they should be doing and seeing the changes after we give those recommendations.
And to tie this back into the first segment we were talking about, it was like, how do we find it? How do we diagnose it? This is why exhausting diagnostic imaging is important, because now we know what grade is it for sure. Like, to see is to know, to not to see is to guess. Don't care. I would rather take a digital x-ray of a foot, and then I would rather get an ultrasound of it and get an MRI if we need it. And do not let everything is clear frustrate you when it comes back like, yeah, I didn't find anything, so that kind of sucked. It's like, no, that's the best thing that could have happened.
Right.
So let's flip the mindset a little bit, because chances are we don't always go to MRI in those cases unless it's like the one you're talking about where,
Right.
Man, that was wild. But we're trying to rule out, not necessarily rule in. And if we do rule in, it just gives us better information to get you better faster.
Right. Yeah. One of the best things we can tell someone is that nothing came back on imaging, or sometimes even nothing came back on some of our diagnostic tests that we're doing in the office. Like, great, let's just make you move better. And a lot of that's going to fix it.
Yeah.
So, I don't really have many more research. I mean, I do, but it would take us a whole nother hour to really go through some of these. But, I mean, it really just shows over and over and over again in the research that doing preventative programs is one of the best things for ankle injuries. And if you're not implementing them with your team, if you're a coach or athletic director or someone that's listening to this, if you don't have preventative programs, a good one, for example, is the FIFA 11 Plus that we've talked about for a lot of lower extremity injuries, including ankles. If that's not implemented as a regular procedure in your program, then you need to start doing something like that and implement it. And if you don't know where to start or what to recommend, that's where something like our services with the evaluation, so that we can basically tell you what your team needs from a preventative standpoint, because we can uncover those things.
And if you want us to, if you want us to come talk to your team, if you want us to, or I don't know, maybe you're in Connecticut and you're hearing this and you're like, we can zoom in, and we'd be more than happy to give you our time and talk about it a little more, because there's a lot of questions that aren't being answered either. So it's like, if you have a team, if you have an organization or a school or whatever the case might be, and if you're local, great, we'll come to you. You guys can come here. We'll set up a night, bring some food in. We'll go to your practice, your parent night, your whatever you want, and we can literally speak on this and even create a bigger relationship where, maybe we go through this with them. Like, we're not opposed to that. We don't always have to be in here in the office. Like, we will give things for you guys to do or have the opportunity, because and when we do things like that, I wouldn't say it's broad in the way that we hide information behind a gate. I would say it's more broad because it's like, okay, you want us to come talk to your football team of 120 kids throughout the high school team. Sweet. Let's put them all there. We will, like, here's what you guys need as we come. Or if you want us to provide it, you need this, and we're going to put you through what we do here in the office and actively have them go through it. And so if you want us to do that, there's 100 plus kids. What I'm getting at, though, is we haven't done a thorough evaluation on every one of them. It's a pretty broad as far as injury prevention of what everybody should be doing no matter what. However, for each one of those 120 kids, athletes, we could be dialing in exactly what they need to be doing as well. And while there is some overlap in our standard protocols of these bulletproofing these injuries, there's also could be very, what if somebody's glute med is super stacked? It's like, nope, that's not the problem. And, what if one of the hamstring, what if you have a lower cross syndrome? What if you have, some sort of antalgic posture because you're injured somewhere else? Or, what is your static or dynamic valgus look like for that individual? It's not so much, oh, they got bad arches. That's another one I'm kind of sick of hearing about. It's like, okay, the foot is the foot. The arch does have something to do with that, but could that also be part of the injury protocol that you need to strengthen the muscles that then wrap those tendons and ligaments underneath the foot that provide support for that arch?
Right.
And so that's where it gets a little more broad, is for 120 of them, unless you come in and do the whole evaluation, but we can get pretty good and provide organizations and teams with some proper bulletproofing techniques.
Yeah. I'll toot my own horn here, even though I can't take 100% credit for it, but 100% credit for bringing it here is we have an ankle protocol prevention as well. We have a prevention protocol as well as an ankle rehab protocol, but the prevention protocol, if put in place with your team, I can almost guarantee you will have zero downtime for ankle injuries over the course of the whole athletic career of each individual athlete. Mm-hmm. And it is proven at a semi-pro basketball level over the course of 4 years that implementing this program, there was zero downtime from ankle injuries, which is unheard of with basketball.
Yeah.
I mean, we could look at the numbers on ankle sprains with basketball, but if this program is implemented, the chances of having an ankle injury or even, like we said, downtime from an ankle injury is almost 0%. And on the other end of that, when ankle injuries do happen, a perfect example of this is we got someone back that was probably around that 3 to 6 week mark of being out back in a week and a half or even less than that. And and she just the other day said she felt like she was close to tweaking it again, but was confident that, you know, she didn't because she was already doing the preventative stuff that we gave her after her initial injury. And she didn't re-injure it which is awesome, because there was the likelihood if she wasn't doing what we gave her, then most likely she would have been worse off, and it would have been worse of an injury than the first time around with the re-injury. But she was able to play the rest of the weekend, and she didn't have any downtime because she implemented the program that we have in place for her.
So I'm looking for exactly what you're talking about. So
the rate of
the ankle injuries
sprains in basketball.
And this is in a percentage, so we don't know what the population is necessarily. Mm-hmm. So you could backtrack and figure that out to an extent, but 45.9%. Well, this is even more alarming. 45.9% of the ankle injuries that happen in basketball, they're out for a week or more of competition. Mm-hmm. And the most common mechanism being landing. Want to know an even scarier one? And this is what we were kind of ranting on a little bit earlier, and in our heart saying, this is, please take care of this. Please ask us more questions. Please be preventative. Please don't just put it in a boot, stabilize it. A couple weeks sucks, but we'll get over it. 56.8% of these ankle injuries did not seek professional treatment. Mm-hmm. And then I want to know on the back end what other injuries happened post that. What was the longevity of the career? What was, but over 56% of them did not seek professional treatment, which is alarming with what is going on right now.
Crazy.
So there's a lot to these ankle injuries. We just wanted to touch on them here for a little bit of time to make it very real, honestly. I mean, there's we'll put up some ways, even on the website at, thepureathlete.com, we can put up some, we'll work on putting up some resources that you guys can, even answer some things or things to look for as parents or athletes, even when you look in the mirror or while they're walking in the store or, whatever the case might be, that might uncover some answers for you that we might want to do this a little faster than we had planned on and not watch and wait. But I mean, I think we can take this to knees on the next episode, but the rate at which the next injuries could happen and what injuries those are, ACL. So, you could talk about the knee, ACL, MCL, meniscus, PCL, patellar tendonitis. You can talk about IT band issues, hip labrum, quad or hip flexor issues, as well as they're all wrapped up in that upper groin area, that because we're displacing weight differently post-injury, whatever the case might be. But of the bigger injuries that you're going to want to know about very immediately to the site is knee and hip. And we're not just talking strain. We're talking about tearing apart a labrum. We're talking about, tearing apart, some sort of soft tissue in the knee, whether it's ACL, MCL, meniscus, PCL. So take this very seriously. Let us help. Ask questions and keep a lookout on the website and contact us. If you have a group or a team, let us come talk. We're pretty good at talking. Well, we're good at talking. I don't know I mean, the context is pretty good, I'd like to think. But let us help, because there's nobody else that's putting in as much time as we are on it. And so we'd love to be able to help where we can. Anything else you want to go over before we leave the foundation of ankle and probably we can move into knee even next week?
No, I think we covered a lot.
Okay.
That's good.
Well, we will see if we can't get some of these articles in the comments or in the description of the podcast. We'll be cutting up some reels on this too, so you can probably find it there as well. But stay tuned if there's any injuries that you would like us to go over or want to understand more, or anything within the world of student athletes and mental physical relationships. Let us know. But follow us on social media. We're going to wrap this one up, and we will see you next time on the Pure Playbook. See ya.